Good evening, everybody. Pardon, sir. Yes, sir. Good evening, one and only. Thanks for being here in your busy evening schedules. Thanks for spending your valuable time with us. We request Dr. M. Subramaniam sir and Dr. C. Rajendran sir to be on stage to accept our felicitation. I request MS. 2 minutes, sir. Bharati ma'am and Vasant sir to felicitate the consultants. Thank you, sir. For our chairperson, we don't need any special mentioning to, is our beloved Professor Dr. M. Subramaniam, Senior Surgical Gastroenterologist, who's been serving the people nearly 5 decades. Sir has completed his MBBS at Madurai Medical College and MS General Surgery in Tamil Nadu Dr. MJR Medical University, MCH at Madras Medical University. He is a former professor of surgical gastroenterology at MMC, and he has been member of many associations in India and Pan-Asia. Welcome, sir. Our first speaker will be Dr. Tarakeshwari ma'am. She has completed her MBBS in KMC, DM in KMC, and she has published papers in HRS in CLD, hepatitis B in pregnancy, and peritoneal mesothelioma. Currently, she is with us as a medical gastroenterologist. Her topic today will be acute severe ulcerative colitis. Ma'am, welcome, ma'am, to deliver the speech.
Good evening, everybody. Today I'm going to talk about acute severe ulcerative colitis. Acute severe ulcerative colitis is one of the common conditions that we see in our daily medical practice. So it is characterized by presence of bloody stools along with fever with any of the following features: fever, tachycardia, hemoglobin less than 10.5 and ESR more than 30. This is according to the Truelove and Witts criteria. So Truelove and Witts criteria is based upon the stool frequency, rectal bleeding, temperature, pulse rate, hemoglobin and ESR. So stool frequency more than 6 with bleeding with any of the following features characterizes as acute severe ulcerative colitis. It is seen in 15-25% of the patients. It can be the first presentation or it can be a flare in patients who are chronically with ulcerative colitis. So the significance why this acute severe ulcerative colitis is significant is that there is a 10-20% likely to need colectomy in their first admission itself. and 30 to 40% risk of colectomy when there are repeated exacerbations of acute severe colitis. So it can present as either proctitis, distal colitis extending only up to the splenic flexure, or it can present as extensive pancolitis. So early diagnosis is important to distinguish it from other causes like infectious colitis, radiation associated colitis, ischemic colitis. So the differential diagnosis is that every bloody diarrhea need not be ulcerative colitis. It can be infectious colitis, especially E. coli, salmonella, amoebic colitis. Cytomegalovirus is common in patients who are already on treatment for ulcerative colitis with immunosuppression. And amoebic colitis also is a common differential diagnosis. In elderly patients, it can be diverticular disease with diverticulitis. Ischemic colitis is also one of the characteristic diagnosis. So on admission, the patient should have the baseline investigations, full blood count, urea, electrolytes, liver function test, especially serum albumin, which is a prognostic factor, and CRP, with which we can base our treatment, whether to continue the steroids or change over to rescue therapy. And stool routine examination and culture sensitivity, and including for Clostridium difficile toxin assay, and plain X-ray of the abdomen, and at least a sigmoidoscopy, especially to confirm the diagnosis with the histopathology and also with the CME screening. If we are planning to start the patients on immunosuppressants, biologicals, then we go for other investigations like screening for tuberculosis, especially before starting the patients on biologicals. So Mayo scoring system, the total scoring system is based on stool frequency, rectal bleeding, and the endoscopic features, as well as the physician's global assessment. An ulcerative colitis endoscopic scoring system is based on the vascular pattern, bleeding or friability, erosions and ulcerations. So vascular pattern, if it is normal, it is 0. When there is patchy obliteration, it is 1. When there is complete obliteration, it is 2. And it is spontaneous bleeding. The friability is more. When there is spontaneous bleeding, the subscore is 3. Erosions is 1, and superficial ulcer is 2, and deep ulcers is 3. An ulcerative colitis endoscopic index severity score, if it is more than 5, then there is a high chance that the patient will become steroid refractory and will need rescue therapy. So here we see the patients with spontaneous bleeding ulcerations, that is Mayo ulcerative endoscopic score 3, severe disease. So comparison between ulcerative colitis endoscopic index score and the Mayo score. Score more than 4 to 6 or Mayo score more than 2 is severe disease. So 50% of patients with the endoscopic index score more than 5 required rescue therapy, and if the endoscopic index score is more than 7, almost all of the patients became steroid refractory. So the significance of doing an endoscopy initially for acute severe ulcerative colitis, one is we can confirm the diagnosis with the histopathology, distinguish it from other causes like cytomegalovirus, amoebic colitis, as well as we can get the severity based upon the endoscopic scoring system. Histopathology shows presence of lymphoplasmacytic infiltrate, crypt abscesses, but crypt abscesses and cryptitis can be there in infectious colitis also. So distortion, crypt architectural distortion and plasma cell infiltration is very characteristic of ulcerative colitis, and if it is Crohn's colitis, you can distinguish it by the presence of granulomas. Amoebic colitis, there will be characteristic ulcers will be seen, and trophozoites will be seen, flat-shaped ulcers and trophozoites. And cytomegalovirus, we can see the characteristic owl's eye inclusion bodies. So the poor prognostic factors, on admission itself we can predict which are the patients who will go in for steroid refractory cases and will need surgical intervention. Age less than 40 years, extent of the disease, if it is pancolitis or extensive colitis, a Mayo subscore 3 or ulcerative colitis endoscopic score more than 7, that is severe endoscopic disease. Presence of elevated CRP and low serum albumin, these are the poor prognostic factors. Fecal calprotectin, this is a protein, it's a calcium binding protein that is secreted by neutrophils. So it is isolated in the stool samples. As a diagnostic factor, it can be used to differentiate between IBS and IBD. It is a marker of inflammation. But in IBD, acute severe ulcerative colitis, it can also be used as a prognostic factor, and values more than 1000 micrograms were found to be associated with the severity of the disease. In a plain film, we can assess for the presence of toxic megacolon with a transverse diameter more than 5.5 and cecal diameter more than 9 centimeters, and presence of mucosal islands or thumb printing. All this can be assessed in a serial abdominal X-ray, first taken on baseline, and then to assess the response after 1 or 2 days and third day also. After correction of electrolyte imbalance, especially correction of potassium and adequate hydration, enteral nutrition itself is better for the patient. There are no studies which support parenteral nutrition over enteral nutrition, and blood transfusion on a case-to-case basis. Then the patient is started on the main therapy, steroids 100, hydrocortisone 100 mg 3 to 4 times per day, or methylprednisolone 60 mg per day. This is a first step of treatment, and then after that we assess the patient serially. The steroid response is seen in 1-2 days itself. If the response is not there in 3 to 5 days, we do not wait for response for until 7 days. So monitoring response with stool frequency, rectal bleeding, physical examination, especially the abdominal examination, and pulse rate, tachycardia, and hemoglobin and CRP measurements, and serial abdominal X-ray has to be taken. The prediction of the response can be made with the Mayo overall score itself, whether the stool frequency improves, the bleeding per rectum, whether it improves. We can also assess using CRP and serum albumin. A CRP level more than 45, based on the Travis-Axford criteria, CRP more than 45 or more than 8 stools per day if present, it becomes a steroid refractory or steroid failure. Then we go in for the rescue therapy. If the stool frequency comes down, patient improves clinically with rectal bleeding comes down, then we continue the steroids for these patients, and then we overlap it with maintenance therapy with mesalamine and azathioprine in patients who become steroid dependent. If the response is not there, that is the stool frequency still remains more than 8 stools or CRP is more than 45, then it becomes steroid refractory. The other criteria that can be used is the Scottish index and the Lindgren scoring system, which incorporates the colonic dilatation and the albumin levels. So in patients who become steroid refractory, we switch over to rescue therapy either with cyclosporin or with infliximab. So cyclosporin or infliximab and a surgical consultation also. So cyclosporin, it's a polypeptide, it's an inhibitor of interleukin 2 as well as other cytokines. It is given as an IV dosage 2 mg per kilogram per day with the target trough levels of 150 to 250 nanogram per ml. So when comparison of the dosage with the 4 mg per kg and 2 mg per kg, 4 mg was not found to be superior. So 2 mg per kg intravenous cyclosporin is sufficient. But the only adverse effects is nephrotoxicity, seizures, paresthesia, hypertension, hypomagnesemia and hyperkalemia, electrolyte imbalance. The other which is commonly used rescue therapy is infliximab. It is a monoclonal antibody against tumor necrosis factor alpha. It is given as IV infusion. The trial was ACT trial, which compared the dosage of infliximab 5 mg per kg and 10 mg per kg compared with the placebo. This is administered at 0, 2 and 6 weeks as IV infusion and then every 8 weeks. In this study, they followed the patients for up to 22 weeks and 46 weeks and found that infliximab was much better compared to placebo, and the dosage 5 mg per kg was sufficient for induction as well as for maintenance of remission. Clinical response is defined as reduction of the Mayo score to less than 3 points and at least 30% decrease of the clinical parameters. Clinical remission is a total score response less than 2 points or lower. But a disadvantage in using infliximab infusions is infusion related reactions. So infusion related reactions, it can vary from either mild pruritus, chills to severe cases where they can go in for anaphylaxis, hypotension, tachycardia, shortness of breath. In some cases, we see delayed reactions, especially polyarthralgia, headache, and sore throat. Biologicals always associated with an increased risk of opportunistic infections also. So that is one more adverse reaction. And a study, construct trial, comparison of infliximab and cyclosporin in steroid-resistant ulcerative colitis, it found that both were equally effective in the patients with acute severe ulcerative colitis. In patients who are not responding to biologicals or who go in for complications like toxic megacolon or severe refractory hemorrhage, then these patients should be referred for colectomy. So acute severe ulcerative colitis, assess on day 1 using true love and WITS criteria and start the patients on steroids. And then day 3 we assess the patients based on CRP levels in the Oxford criteria. Complete responders, we continue with the steroids, slowly taper it 5 mg per week and then overlap it with azathioprine and mesalamine. In incomplete responders, we go in for medical rescue therapy or surgery. Now we have some newer agents. So apart from the biologicals, we have small molecules, JAK inhibitors, tofacitinib. It has been studied in moderate to moderate severe ulcerative colitis and it shows promise for acute severe ulcerative colitis, although future trials are needed to support this use. It is an orally targeted synthetic small molecules. It acts by inhibiting the competitively and reversibly inhibiting Janus kinase. It has a rapid action, rapid absorption as well as a short T-half of 3 hours. So it can be used for acute severe ulcerative colitis, whereas the biologicals, it takes nearly 6 weeks for the response to be assessed. So compared to biologicals, this has an added advantage. But the risk factor or the adverse effects is that opportunistic infections, which is similar to biologicals, is there, and there is an increased risk of venous thromboembolism as well as cardiac thromboembolism, and non-melanoma skin cancer when used for long term, and nasopharyngitis as an acute reaction. This is the OCTAVE trial in both induction as well as sustained trial for induction regimen as well as for maintenance therapy with tofacitinib. For the induction, they used a dosage of 10 mg BD, and for maintenance, they used compared 5 mg as well as 10 mg, and they found that it was effective compared to the placebo. Statistical significance was obtained, and for maintenance 5 mg BD, but with 10 mg dosage, the adverse effects is more. So even for induction, 5 mg BD can be used. The other agent that has been tried in acute severe is vedolizumab, but it's probably less suited because it takes at least 4 to 6 weeks for the response to happen. So the base of the pyramid is going to be steroids and the rescue therapy with cyclosporin, infliximab. The other newer biologicals like adalimumab, golimumab, it takes a longer time for response to take place. And we have the newer molecule, this is tofacitinib, which shows promise in acute severe ulcerative colitis. So we had a patient, a young female who presented with acute severe colitis following pregnancy. So the inciting precipitating factors can be NSAID use and pregnancy also. She was managed with steroids and she responded. And subsequently when she was on azathioprine, again she had one more episode of flare. And the endoscopy showed presence of punched out ulcers in the colon, and when we took the biopsy, typical ulcer inclusion bodies were seen. But the controversy regarding CME colitis is whether it is a pathogenic agent or is it a simple bystander. So we go in for CME PCR analysis, quantitative analysis, and CME PCR quantitative analysis more than 200 as a cutoff. It's a specific factor to show that it is a pathogenic agent, and CMV colitis for this patient we treated with ganciclovir and the patient improved well. So biopsies from the base of the ulcer have the greatest yield, and immunohistochemistry staining as well as PCR based assays are needed to diagnose CMV disease. And treatment is IV ganciclovir 5 mg per kg twice daily for 3 to 5 days, and then switched over to oral ganciclovir 900 mg twice daily for 2 to 3 weeks. Venous thromboembolism is another risk factor which can occur in acute severe ulcerative colitis as well as in chronic ulcerative colitis. So, prophylaxis with compression stockings and subcutaneous heparin is indicated. So, DVT prophylaxis to prevent venous thromboembolism is indicated in according to the ACG guidelines. And in patients who have concomitant Clostridium difficile infection, they recommend vancomycin over metronidazole in patients especially with ulcerative colitis. So, acute severe ulcerative colitis, we have to differentiate it from other infectious colitis, and the assessment of response should be within 2 to 3 days to switch over to either rescue therapy or for surgical referral. And if there is superimposed infections like CME colitis as well as with Clostridium difficile infection, it has to be treated concurrently along with the treatment for inflammatory bowel disease. Thank you.
Thank you very much for the exhaustive explanation about the acute colitis. So, when the acute colitis settles down, it will go into chronic colitis. So, ulcerative colitis can exist for many years. What is the incidence of malignancy?
Malignancy is 4 to 8% incidence of malignancy is there.
So, how do you advise, how frequently you advise colonoscopy in the...
After 8 years of patients with ulcerative colitis, then they have to go on for surveillance. Surveillance every year, full colonoscopy surveillance every year, and based upon the biopsies has to be taken, segmental biopsies as well as every 10 centimeter biopsy has to be taken. And if there is dysplasia associated lesion or mass, depending upon the degree of dysplasias, then we advise subsequent colonoscopies.
So you told pregnancy gives relief, aggravates the condition or relieves the condition.
Pregnancy is a 1/3 rule, sir. In some cases, 1/3 of patients with pregnancy, ulcerative colitis remains the same. 1/3 of patients do better, and 1/3 of patients it aggravates. So there is a flare in patients with ulcerative colitis and pregnancy in 1/3 of patients.
I was under the impression that smoking aggravates the disease in males, and pregnancy gives remission. That's what I was...
Pregnancy, 1/3 rule, sir. 1/3 of patients it goes in for remission, 1/3 of patients there is a flare of ulcerative colitis.
So, when will you transfer the patient to the surgeon?
When there is a medically refractory disease in the form of rectal bleeding which is not controlled with rescue therapy as well as with steroids, or there is a toxic megacolonic dilatation, then we advise for a surgical.
So, any other questions from the audience?
Sir. Yeah, it's a good speech actually. Thank you, madam. But one thing is that in this, you told me that depending upon the degree of dysplasia, the surgery can be contemplated. But to the best of my knowledge and subject to the correction by my senior colleagues, any degree of dysplasia in the background of ulcerative colitis or inflammatory bowel disease is a definite indication of surgery. Subject to correction by Sir Sivaraj sir and Subramanian sir. Thank you. Contrary to other conditions, other pre-malignant conditions, any degree of dysplasia, mild dysplasia, moderate or severe dysplasia, is an indication for radical surgery. Is to the best of my knowledge. Thank you.
Usually high-grade dysplasia or this carcinoma in situ is an indication for surgery, but these mild dysplasia patients, they need follow-up.
Basically, it is a disease to be managed by the physician and surgeon.
Yes.
So it should be combined symbiotic treatment. It's not a single person treating the same thing. Whenever the medical treatment is failed, he has to hand over to the surgeon for further treatment.
Yes, sir. In the acute severe ulcerative colitis, first time presentation itself, side by side, we take
That is important.
X-rays and get a surgical consultation.
How will you differentiate from this thing, irritable bowel syndrome? Most of the patients will have things with the mild form of ulcerative colitis. How will you differentiate?
irritable bowel syndrome, there may not be characteristic ulcers, and colonoscopic biopsies will not be characteristic of ulcerative colitis, and fecal calprotectin levels will be less than 150 nanogram per ml. So all these factors will be there in patients with IBS.
Most of the patients will come with IBS symptoms, but their colonoscopy may be normal. Vascular pattern sometimes there will be change. Sometimes we are not able to differentiate. Any other method to differentiate this condition from ulcerative colitis? It may not be acute ulcerative colitis, but mild form ulcerative colitis. Any other
if features of after ulcerations or histopathology shows presence of crypt distortion, then it is ulcerative colitis. If any of these factors, that is histopathology, is not conclusive, or if the mucosa is normal, then we consider it as irritable bowel syndrome. Even if few after ulcerations are there, we treat it as ulcerative colitis only, not irritable bowel syndrome.
The role of surgeons, you have said about the intractable bleeding, and you also said about the patient going for toxic megacolon. The other thing is, even you can clinically assess the patient. If the patient goes in for sepsis, if the patient is showing acidotic type of an ABG, that says, and the lactate level is very high, that says the bowel wall has lost its integrity, and there is transmigration of the bacteria from the bowel wall into the peritoneum when the patient is going for sepsis. There's another indication for surgery other than malignancy, what he has said. I concur with Dr. Sivaraj, only in high-grade dysplasia and carcinoma in situ, you go in for a radical surgery, otherwise you observe. If the patient is there for 10 years history of ulcerative colitis, then you will have to make a good surveillance and you will have to have a good follow-up. Even a mild dysplasia must be taken into account if the patient is having ulcerative colitis for more than 10 years. That's what it is.
Yes, frequency of coroloscopic surveillance has to be more, and if it turns out
You will have to take a biopsy, as you said, segmental biopsy or doubtful areas. And also when you inflate the colon, you can see whether the colon is rigid in that part or inflating nicely. The distensibility of the colon also will tell you whether it's going for malignancy or there is something wrong there, especially when the patient survives more than 10 years with history of ulcerative colitis. Thank you.
If there are no questions, we will go. Thank you.
Thank you.
Thank you, ma'am. Thank you so much. I request Dr. Priya, ma'am, to felicitate. Thank you, ma'am. Thank you so much, ma'am. I request the next speaker, Dr. Padam Kumar, to be on stage. Sir has completed his MBBS from Chengalpattu Medical College, MS General Surgery from MMC, and his area of special interest is minimal invasive surgeries. He has published articles on laparoscopic procedures in various journals. Today's topic is dyspepsia. Think beyond the gas.
Very good evening to the respected chairperson, my fellow senior speakers, and to one and all present over here on a fine Saturday evening. I think amidst a long holiday weekend, you are all here. Appreciate you all. So I am going to talk about dyspepsia, a case scenario followed by some practical guidelines. I hope I'll not bore you much. So straight away, this is our patient, a 29-year-old IT professional who came to us with complaints of dyspepsia and vague abdominal pain on and off for the past 6 months. So for the past 10-15 days, he had severe episodes almost daily, and he's had a fear of eating, so he's lost weight gradually. So as usual, many doctor visits, thinking it may be cancer, it may be TB, it may be HIV. So he's undergone the ultrasound abdomen showed a loaded colon, otherwise normal. His basic blood workup, that is liver function test, complete hemogram, ESR, amylase, lipase, CRP, everything was normal. So they did a CT abdomen, which was also not helpful. So he was managed with PPIs, probiotics, laxatives, and a lot of other supportive medications, but still he was not getting much relief. So he consulted us. As the 9th doctor, we saw him because of his progressive symptoms. Clinically, he looked thin-built, otherwise his abdomen was fine, no tenderness. The only thing is, he has not underwent any upper GI endoscopy in the previous 8 visits because of fear. So somehow we counseled him and made him get an upper GI scopy done. The upper GI scopy showed just mild antral erosions, otherwise normal. So we had sent a tissue for Helicobacter pylori, which was also negative. So what next? Patient is there. Almost 9th doctor, we were the treating physician. He's had gone a battery of tests, no response. But he had typical pain and especially postprandial pain. So we thought about a HIDA scan to rule out gallbladder dyskinesia. So a technetium 99 hepatobiliary scintigraphy was done. So this is his HIDA scan. So HIDA scan is basically done to see the function of the gallbladder. See the ultrasound, CT scan, MRCP, all those will show you the structural problems. If you want to find out the function of the gallbladder, it is the HIDA scan. So in his HIDA scan, we could see that the radioactive, that dye is still present only in the gallbladder and it's not going down. So this is the pre-fatty meal. Pre-fatty meal is the image. Pointer, excuse me. Okay, fine. So pre-fatty meal studies showed radioactive dye in the gallbladder, and then he was given a fatty meal with a slice of bread and butter. Generally cholecystokinin is given, but here because of economics we give a fatty meal that works like a CCK and stimulates the gallbladder. So post fatty meal 15 minutes, 30 minutes, 45 minutes they had done a scan. Still that dye was present only in the gallbladder. So this is the graph showing the ejection fraction. Like the cardiologists see the ejection fraction of the heart, this scan shows the ejection fraction of the gallbladder. Ideally, it should be more than 35%. Anything less than 30% is significant of biliary dyskinesia. His EF was only 12%. So the final report came as normal sized liver with good liver function and post fatty meal challenge, severe gallbladder dyskinesia with chronic cholecystitis. So he underwent laparoscopic cholecystectomy. It was a straightforward surgery, normal Calott's anatomy, uneventful, and post-op he recovered well. The histopathology report came as chronic cholecystitis. Post-procedure, he looked comfortable. He started eating fine, and he's gained around 4 to 5 kgs in the next 2 months. And of course, long-term follow-up is required. So coming to the discussion part, diagnosis is the key here. So whenever a patient presents with dyspepsia, we do a lot of tests, but also we need to keep biliary gallbladder dyskinesia in our battery of differential diagnosis. So the criteria used here is Rome 3 criteria. So I think this is the most important slide of the talk. Whenever you see a patient with dyspepsia presenting to you with repeated abdominal pain, in the upper quadrant on the right side or the center, along with all these criterias. 1, gallbladder is present, his liver enzymes are normal, his amylase lipase are normal, the pain lasts for 30 minutes or more. Like a biliary colic pain, it lasts for half an hour or more, and the patient has recurrent episodes of pain at different intervals, maybe 2 times a week or 3 times a week, and the patient has severe pain that he has to come to the hospital or to the emergency room to get the painkiller done, because that pain is not relieved by normal antacids or PPI or postural changes or bowel movements. So when all these criteria is present in a patient with recurrent episodes of abdominal pain, keep gallbladder dyskinesia as a differential diagnosis. Of course, when such patients come, we also think of all these differential diagnoses: biliary colic, which can be easily picked up on an ultrasound or MRCP; pancreatitis, of course, amylase lipase will be normal; GERD or peptic ulcer disease will be picked up on endoscopy; kidney stones, etc. Also, in such patients, I have not put here, we can do a CT scan in thin patients especially to rule out superior mesenteric artery syndrome or malrotation of the gut. Now next question comes, if this patient had a normal HIDA scan, what you would have done? So I would have managed this patient as per the ACG guidelines for the patient with dyspepsia. So this is the guidelines. So any adult patient coming to you with dyspepsia, endoscopy is done. If you find any structural abnormalities or an ulcer on endoscopy, treat as per the finding. If the patient has a H. pylori positive, treat according to H. pylori regimen and complete the 2-week course. If the H. pylori comes as negative, give him a course of proton pump inhibitors. Trial inhibit PPI for 2 weeks. If you find some response, continue for 2 more weeks. If you find no response, go for TCA, tricyclic antidepressants like amitriptyline or a prokinetic, domperidone, lesuride, levosulfide. Still no response, then he has to go for a psychotherapy. So you may be seeing patients with functional dyspepsia. Patient has recurrent episodes of abdominal pain. They take a lot of medications. They consult multiple doctors, still no response. So this is the line of management. First, rule out Helicobacter pylori. If that is ruled out, then give a course of PPI, proton pump inhibitors. We give generally esomeprazole. If no response, go for tricyclic antidepressants, amitriptyline 10 mg HS for a period of 2 weeks. If you find response, continue further. If no response, go for a prokinetic. Still no response, go for psychotherapy. The problem here is all our patients come with tablet Pan-D, tablet Razo-D. So the protocol for management should be this. Go for H. pylori treatment. For all the youngsters, go for H. pylori treatment. If H. pylori is negative, give PPI, plain PPI, rabiprazole, omeprazole, esomeprazole, pantoprazole. No need of any prokinetics in the initial stages. If no response, tricyclic antidepressants. No response, go for prokinetics like domperidone. Still no response, go for psychotherapy. So this is how you manage a patient with dyspepsia. Hope this talk was informative. Thank you.
Thank you, sir.
Any questions from the audience?
In our experience, I think Professor Subramaniam is there and Sivaraj is there. This biliary dyskinesia
Yes, sir.
has not helped us by doing a cholecystectomy at all. Ejection fraction was low with the isotope scan. Everything was there, but the cholecystectomy has not relieved his pain. This is our experience. Probably your literature may show that there is an experience.
Yeah, literature shows more than 75%, not 100%, sir. More than 75% response to cholecystectomy,
This
sir.
is our own experience over a period of about 40 years.
Yes, sir.
It has not helped. Majority of these patients who have got pain abdomen where the etiology or the pathology could not be fixed will be invariably landing with a psychiatric patient, psychiatric treatment, and majority of them they do well. This biliary dyskinesia, I am not able to take it easily because we have stopped doing surgery for biliary dyskinesia long back. This is a quite new thing you're telling me. Probably the latest literature you may be showing.
Yeah, that's what, sir. 75% response, I think, is fair enough, giving the option of...
Can you quote some papers on that literature?
Sir,
Evidence?
I have not attached here, sir, but recent I have gone through a lot of literature, NCI and ACG guidelines.
What I am saying is about 20 years, 30 years back story of biliary dyskinesia, where the treatment of any sort is not going to help the patient, because majority of them are hypochondriac.
But when ejection fraction is so low,
So many we have seen 35, 25. We used to do isotope study, ejection fraction low. We do that, they don't do well.
I agree with Tirunavakar sir. Because why did you do HIDA scan? Why don't you do a oral cholecystogram? That will show a better picture than the HIDA scan. HIDA scan is mainly used for the biliary leak. You can find
Yes,
out
sir.
whether the leak is present or not,
Yes,
whether the
sir.
function is there or not. Suppose most of the patients with the gallstones have a good function. So we don't operate unless there is some symptoms are there. How do you rule out the sphincter body dysfunction? How do you rule out the biliary dyspepsia? How do you rule out the ulcer dyspepsia?
Sir, in sphincter of-
appendicular dyspepsia? So many things are there.
Yes, sir. Yes, sir.
Dyspepsia is a vague term.
yes, sir.
So you straight away don't go if the ejection fraction is less than 20%, 30%. Don't remove the gallbladder. Even for the stones, if the stone is not symptomatic, we don't remove the gallbladder. So don't go and remove the gallbladder if the biliary dyskinesia shows some less amount of ejection fraction. So that is not an indication. Don't.
Chronic cholecystitis.
So that will show.
That is different. To be very precise, this biliary dyskinesia is not very sweet to the ears of a surgical gastroenterologist.
Without stones,
It's not palatable at
cholecystitis
all.
occurs only in the surgical ICU patients. When the patient is in total parenteral nutrition.
Yes, sir. That is
So
acalculous
acutely
cholecystitis in
A-calculus
very sick
cholecystitis
patients.
occurs only in those patients, not in other patients.
Sir, but in
biliary dyskinesia is a vague term. So most of the patients will have faint phobia. So you should treat the phobia patients for the particular thing.
Yes,
so
sir.
because this is dyskinesia when the ejection fraction less, you don't go and remove the gallbladder. That's not indicated. So even for gallbladder carcinoma in the endemic regions, when even the presence of stone, they don't go to prophylactic cholecystectomy. It's not indicated. Even though stones are responsible for produce of stones, and the gallbladder stones are North India, the Ganges belt, the incidence is very
High incidence.
But they don't remove the gallbladder. There is no indication of prophylactic cholecystectomy. But you are removing a normal gallbladder because the HIDA scan shows a biliary dyskinesia. I don't think it is.
Yes, a
correct.
patient had the
Sunny, what I am trying to tell you is,
histopathology chronic
Doctor, what I-
cholecystitis.
hello, what I am trying to tell you is, over a period of time, you will have a lot of load on your head. These patients will come and sit on you.
Yeah.
You have operated on
What
you,
happens
are
is-
not relieved.
Already these patients are psychiatric patients, and this cholecystectomy will precipitate a severe reflex, biliogastric reflex, and they will sit on us. So we have to be very careful in selecting these patients.
That is important.
Yeah.
You should have done a oral cholecystogram. Definitely it would have gone into the gallbladder.
Sir, based on the patients, because he had typical symptoms of postprandial pain and loss of weight with the low ejection fraction.
Pain phobia.
No, we have to consider this diagnosis, but you should be careful in
Choosing
selecting the patient because
Point well taken, sir.
because when we were MS students, at the time there is a surge of this scans being done and lot of patients being diagnosed with this one. Then slowly everybody burned their hands and started coming down. We have seen a surge of these scans, and we have also seen a fall of this number of scans happening. So cholecystectomy in a patient like this has to be taken with a lot of consideration before undergoing cholecystectomy, because these patients will be psychiatric patients, and when they come with in addition to this, they have gastritis also, then they will come and eat our heads.
This patient is followed for almost 6 months and
Good.
is doing fine so far, sir.
Very good, very good. That's good.
No, all the
That
best
is
for
good.
you.
That is
all the
good.
best for you. But we'll have to be careful. It's quite logical what you say. Ejection fraction is not there, so that there is a biliary pain, there is this thing and all. It is to the truth. It is not so.
Maybe your experience, you may have.
As
yes, sir.
says, we have
Point well
stopped
taken, sir.
operating on biliary dyskinesia on part of time. That is about 20-25 years back.
Thank you, sir. Thank you so much for such an interaction session.
Thank you, thank you.
Thank you. I request Dr. Gnanashekharan sir to felicitate Dr. Padam Kumar sir. Thank you, sir. Thank you so much.
It's just want to say that very valuable inputs from my seniors and everyone. And additionally, I want to say that Padam has got a very, I would say, very fortunate hands. So, so far he has got everything went on well, and I hope so it will continue. So, thank you. Thank you. Happy to be associated with the Badam also. Thank you.
Thank you, sir. Thank you so much. I request the next speaker to be on stage, Dr. Shankar Narayanan. He completed his general surgery. He is our gastroenterological surgeon and gastroenterological onco-surgeon at our hospital. He has his post-graduation in the field of gastroenterology at SRMC. He has worked in Delhi, NRC, and JIPMER, and he holds a fellowship from Asian Medical Center, Seoul, South Korea. His special interests are minimal invasive gastroenterological oncosurgeries, HPB, and robotic surgeries. Today's topic, sir, is going to discuss about hands-assisted laparoscopic surgeries.
Good evening, one and all, respected chairpersons, senior faculty members, and all the other consultants who have taken time to attend this meet. Welcome you all. First of all, thanks to our management for providing such a wonderful occasion to bring all together. Sorry. So today I'll be talking on hand-assisted laparoscopic surgery, and in this I'll be showing a small video of a colorectal procedure being performed. So first of all, I'd like to express my gratitude and thanks to my mentor, Dr. Amanjeet Singh, who has been routinely doing this for the last 10 years. And when I was working in the previous institute, he was the one who inspired all of us to do this procedure. So just a brief history about minimally invasive surgery. So it dates back to BC, where speculum was first invented, and subsequently much later that is also a speculum, sort of a speculum with a light, which was invented, following which the first cystoscope was in 1879, and then came the term laparoscopy. It was then called celioscopy because it was like the dome, and it was basically gasless laparoscopy. And then came the invention of Verey's needle, and finally the light system, Hopkin rod system, and the insufflators were in 1966. And then we all know Hassan's cannula and Hassan's technique. And subsequently, a lot of innovations came up. And now we have all the arena of gadgets and equipments to do a comfortable laparoscopic procedure. And right now, standard of care for most of the procedures are laparoscopy. So basically, it's a long road, and we've come across a long way, and there is still more to go and see what is at the end of the tunnel. So this is not something where we go and stop. We have to keep modifying our techniques. And the aim is not to produce fanciness. The aim is to achieve the end point without compromising on the oncological safety or the safety of the patient. So the basic difference between open and laparoscopy mainly to me is loss of tactile sensation. And this technique, the main advantage is restoring that. So hand-assisted laparoscopic is nothing but inserting our non-dominant hand into the abdomen of the patient, where one part of the retraction or any other major traction or control of the bleed has been taken care by our non-dominant hand. And of course, our dominant hand uses for instrumentation. So this helps in precise dissection, and it largely reduces the operative time. So the outcome is better, there is minimal blood loss, and the same port which is created in the start of the procedure can be used for specimen extraction as well. So it saves a lot of time. our main or requirement to do a comfortable procedure, laparoscopic or open procedure, is our OT table. And positioning the patient is to be done carefully. And for colorectal procedures, we need a steep Trendelenburg procedure, almost close to 90 degrees also at times. So strapping of the patient to make sure that patients don't slip or slide over, and giving importance to DVT pumps before we start the procedures of utmost importance. And second, for establishing a good pneumoperitoneum, hand port is very important. And there are these expensive gel ports, but in our day-to-day routine practice, we use this. This is a very cheaper alternative, and it's basically a wound retractor, which is inserted into the abdomen, and we use a double glove technique, which can help to maintain the pneumoperitoneum without any gas leak. So in the OR, the surgeon and the assistant stands to the right of the patient, anesthetist on the head end, and the instrument tray and staff nurse on the foot end. So basically, we put the patient in Lloyd Davis, and the surgeon also has his access to the perineum in order to do a per-rectal examination as well if the need arises. And the monitor is placed just opposite at the left foot end. So this is a general for any laparoscopy. The monitor should be at the eye level of the surgeon, and the table should be positioned at the pelvic level of the surgeon. So in order that we don't overstretch our shoulders or have a comfortable angle of instrumentation. So this is again the basic of laparoscopy, where the port position has to be, the triangulation needs to be kept in mind. The angle should not go more than 90 degrees. So in this upcoming video, where I'll be showing a colorectal anterior resection being performed. So the port position is in such a way that we use a 5 centimeter periumbilical incision. So 2 centimeters above and below, and it is curved over the umbilicus as shown in these photographs. So there is also one port which is a 10 millimeter port in the right hypochondrium. So this has to be carefully marked, because in case for these patients, if we need to also do a diverting loop colostomy, the same incision can be used. And with respect to the triangulation, on the spino-umbilical line, a small 5 millimeter port is placed. Yeah. So this is the start. We palpate for the sacral promontory, and with the non-dominant hand, we are able to lift the sigmoid comfortably. As soon as that is done, the pneumoperitoneum itself helps us to identify the plane. Once the nick is done with the harmonic scalpel, we start the dissection from medial to lateral, and our first aim is to identify the ureters. So once that is done, then we move towards the pedicle ligation. We go towards the inferior mesenteric artery and vein. So as you can see, the traction and counter traction is precise. There is no undue over traction or tearing of tissues. And in this point, we are able to clear the lymphatics and the nodes comfortably and apply clips. So even if we encounter a bleed, our thumb and our index finger can be used to control that bleed and have the whole procedure very smoothly running without major blood loss. Then we do the lateral mobilization, and as soon as that is done, we are now entering into the lateral plane, and up to the splenic flexure, we will be able to mobilize with this port only. And next we are going to the posterior dissection. So we follow something called rules of O's and triangles. So the apex of the triangle, as soon as we make a nick with the harmonic scalpel, the apex of the triangle needs to be done. We should not go towards the base, in which case we will injure the vascular plexus posteriorly. So this is again the loose areolar tissue. If we follow the cobwebs, we'll always be in the right plane. And now we are now performing the medial and lateral mobilization as well. So our hand actually helps continuously in changing the angle of traction so that the view is always kept very precise. And the cameraman also need not struggle much because they are right behind the hand, and a minimal angle of rotation is enough to show all the structures, and we will be able to comfortably proceed with the complete dissection up to the levator ani. After the posterior mobilization is done, then we go on to the peritoneal incision on the bladder region. So this is when, after we do anterior and posterior simultaneously, then we go to the sides, and this is when we'll start to find the seminal vesicles that is coming into the view. So, like I said, first the ureters are gone to the sides. Now we have to be careful about, this is a male patient, so prostrate and seminal vesicles needs to be kept in mind. So the plane is just one layer below the seminal vesicles. So after this is being done, we are almost through. This is actually an anteriorly placed tumor, so we are trying to go as close as possible to the seminal vesicles. So once the dissection is carried forward, there is not much of difficulty going down and completing. Another advantage of this hand inside is, after complete mobilization, most of the times, because in pure laparoscopy, we will be having difficulty to identify the distal-most tumor margin. Whereas in this, our left hand can go comfortably and palpate for the distal margin. And once we are sure that we are gone below that, and we'll also do simultaneously a perrectal examination after occluding with our left thumb and index finger, that there is no more tumor or any other lesion in the distal part, then we go ahead and fire a linear cutter endo-GIA stapler. So this is the complete field with the distal stump. Then again, we mobilize some more of the splenic flexure. After which, it's very simple. We have to exteriorize the whole specimen, and we take the purse string sutures first and then transect it. So once this is done, we will next introduce an anvil of the circular stapler. So now the care should be taken not to injure or not to damage the purse string suture which was previously taken. So we tighten the anvil, and again we put it into the hand port. Again the glove is fixed, pneumo is created. So now we are ready for the stapler to be inserted from the rectal end. So once this is done, everything is kept under vision, and the engagement of the circular stapler is done. We take care that the seminal vesicles or bladder is not coming in between the staple, and then the stapler is fired. So basically this negates the help of a equally qualified assistant. That's very important, because we need to have a equally trained or more trained person for us to retract and show in most of the difficult cases. Whereas this hand technique, you can even do it with a good camera person, and everything will be most often in our control. So like I said, tactile feedback, precise dissection, and sometimes even finger dissection is possible with hand port. So as opposed to an open procedure, so this is the scar. These are two of our patients recently performed. One is an anterior resection, and the other one is sigmoid volvulus. So both have been comfortably completed using this hand port technique. So in general, it's not very popular, and not many are comfortable with this hand port technique. So I would like to think that any procedure, it's about repetitive steps, and comfort comes with performing it on a day-to-day basis. Second, the triangulation port placement is a key factor, so that we don't have any undue discomfort at the end of the procedure. And generally, when someone says it's an inferior technique, we all would agree that conversion to open is never a procedural or a surgical failure. It's always the patient safety that has to be kept in mind. And finally, there is also a thing that it may obscure the vision, but with a team which is constantly doing this, it's not going to be a problem. So here at our center, we have successfully completed around 5 cases, 1 abdominoperineal resection, 2 anterior resection, 2 sigmoidectomy for volvulus. And 1 more, we have also done a hand-port splenectomy. So all these patients have a minimal scar, and their recovery is comparable to a patient who has undergone a pure laparoscopic surgery. We start the patients on sips of water the first day, on 30 ml of clear liquids the second day. If they are tolerating well, the RILE is removed on the first day. We ambulate the patient on the first day. Clexane or some DVT prophylaxis is started after 24 hours. And after the second day, we start the patient on 30 ml of clear liquids, then complete liquids as per tolerance, and then move towards soft solid diet. And then by day 5, they are fit for discharge. In following this protocol, if there is any hindrance or patients are not able to tolerate it, we go back and we have a low threshold for repeating any sort of investigation or even to do a repeat CT scan, just to be sure that we don't miss anything. And we are able to discharge the patient by maximum day 6. So compared to open, we all know that what is the advantage of laparoscopy. So I would just like to suggest that hand-assisted is just a bridge. It's not an inferior technique, and at the same time, it reduces the steep learning curve which is involved for most of us. And if it's done repetitively, we will be able to achieve good outcome with less operative time, and the oncological safety is also 100% as compared to any other technique. Thank you for the opportunity.
I've got 2 questions.
Yes, sir.
Number 1 is, you said in the last few seconds before that compared to the complete laparoscopic procedure, the recovery is little faster when you do an hand-assisted.
No, sir, I said comparable, sir.
Comparable.
Comparable. It's not inferior, it's non-inferiority.
It's not inferior.
Yes.
Okay. Now, second one is there any compromise on the oncological clearance when you do a hand-assisted? As you said, you will do as a finger dissection technique. Will you compromise anything on that? In a laparoscopy, you've got a clear vision of the whole pelvis. Whereas when you put in a hand, you're likely to leave back a little bit of a mesorectum. Probably you may see it again with the laparoscopy. What is any oncological outcome with hand-assisted laparoscopy, pure laparoscopy? Is there any paper, any trial?
Yes, sir. There is a big meta-analysis. In fact, our previous center, when I was working there at Medanta, the Medicity, we have published a series of 500 plus cases, sir. So the oncological outcome is same as pure laparoscopy or even open surgery. In fact, this is more precise in the TME plane, because when we lift with our own hand, there is not pulling or tearing of tissues. The plane is maintained in a smooth manner. I mentioned the finger dissection not for this procedure, sir. In general, for other, we'll be able to palpate if it's IMA or any other structure. Even during splenectomy, we can palpate the pedicle before firing a vascular stapler or something. So not for TME, sir. Thank you.
So will you stick on to the hand-assisted technique, or you want to switch over to laparoscopy or robotic surgery?
Sir, at this point of time, I'm very comfortable with the hand-port and hand-assisted procedure. But definitely, I have to move towards pure laparoscopy. But if I have a case which is like this, which is post-neoadjuvant therapy and not a male who is slightly on the bulkier side, I would definitely go to a procedure which I am comfortable with, sir. This is just personal opinion.
In Medanta, were you under Adarsh?
Yes, sir.
Adarsh is slightly skeptical about the laparoscopic procedure. He
Yes, sir.
likes
Sir,
more of a open procedure.
Yes, sir.
That's what I want to know.
Definitely, sir. Sir does more of HPB work. Next to Dr. Adarsh Chaudhary, there was Dr. Amanjeet Singh. So he is the one who's been doing this on a routine basis for the last 10 years, sir. So he was the one who has inspired me to do this procedure.
Still the port is available, huh? Hand port.
Yes, sir. We have it in our OTs.
Thank you, sir. Thank you so much.
Thank you all.
I request Dr. Raju Karthik sir to felicitate Dr. Shankaran. Thank you, sir. Thank you so much, sir. Next speaker is Dr. Shivaraj, sir. I request you on to be on stage. Sir has completed his MBBS from Madurai Medical College, MS General Surgery at MMC, and MCH at Stanley Medical College. He is our senior consultant surgical gastroenterology, serving more than 2 decades to the public, and he has obtained a fellowship in minimal invasive bariatric surgery in 2014. Sir has undergone a comprehensive training in minimal invasive upper GI surgeries. Sir has published a lot of papers, books, and publicity to his glory. Sir received Best Paper Awards in Indian Indian Association of Surgical Gastroenterology Conference held at AIIMS in 2007, and Best Scientific Poster Award in IHBPA in 2009. It's an international conference. Today's topic, sir, will be discussing about Whipple's pancreatiodectomy in dilated cardiomyopathy.
Today is I thought of talking about a Whipple pancreaticoduodenectomy in a case of postpartum dilated cardiomyopathy. This patient present to us with, as a 52 years female with an yellowish discoloration of eyes for the past, for almost 18 days, with a history of episode of vomiting and pain abdomen, but there was no history of fever. She is a known case of postpartum dilated cardiomyopathy who was on follow-up with one of our senior cardiologists for 25 years and was on treatment. She is not a diabetic or a hypertensive. She was under good medical follow-up, and she was not having any episodes of acute cardiac illness in the past. On clinical examination, she was a thin-built patient, and she was icteric. There was no signs of acute cardiac illness failure like elevated JVP or a pedal edema, and clinical she was able to claim 2 flights of stairs without dyspnea, and she was on these cardiac medicines with digoxin thrice weekly and angiotensin converting enzyme inhibitors for her dilated cardiomyopathy and diuretics. Because this patient was an young, middle-aged patient and who was thin-built and who was, she was very active lady, and the disease also was it was not metastatic. Then we started investigating this patient, and we got a cardiac witness. Her ECG showed a sinus bradycardia with a premature atrial complexes and a non-specific intraventricular block and a left bundle branch block. And an echocardiogram showed a 27% ejection fraction with a severe left ventricular dysfunction, and left ventricular enlargement was present, and there was a global hypokinesia was present. But in spite of all these echo findings, she was fit lady. She was able to carry out her normal activities. So endoscopy showed a periampullary growth, and when the biopsy was done, it showed a well-differentiated pancreatic ductal adenocarcinoma. There was a bilirubin was 21 milligram, and CT showed a dilated CBD with intrahepatic biliary radical, and there was pancreatic duct also was nicely dilated. So she had a favorable anatomy for anastomosis, and the PET scan was done to rule out any other distant metastasis. there are no distant metastases. It showed only a metabolically active soft tissue lesion in the periampular region extending into the head of pancreas. So periampular carcinoma, probably pancreatic type, and it encased the terminal bile duct and pancreatic duct with proximal biliary and distal pancreatic dilatation. So there was a good dilatation of the pancreatic duct and bile duct. So a patient was sent for being a young patient with the early disease, with no metastasis, and a good ductal anatomy for reconstruction, and who was on continuous follow-up with the cardiologist for a long time, and with reasonable good function. So we thought we will proceed with surgery for this patient, because this periampular carcinoma is only going to spread if we are not operating, and let us with carefully we will plan for a resection, and we will have a plan of coming back, stopping the surgery at any point of time before going to a point of no return. So we took her for anesthetic fitness. So anesthetist gave a fitness with the high risk consent with the ASA3. So this was the preoperative plan of the anesthetist: have arterial lines, fluids under CVP guidance, and prepare to deal with any arrhythmias or hypotension. And surgically, we had a plan of proceeding with the laparotomy and assess for resectability, and proceed with the mobilization of the head of pancreas, bile duct, proximal jejunum, but not to divide any structure till complete mobilization, and then reassess hemodynamically the patient so that she is not going for any arrhythmia or hypotension during the procedure, and if anything is there, to stop the surgery at that point of time. And if the patient is stable till these steps, then to divide the bile duct, stomach and jejunum and neck of pancreas finally. So if we are not able to continue this, to go for a bypass. So by a bilateral subcostal incision, we opened the abdomen and we found a growth in the periampular region with some narrowing of the duodenum, and there was no peritoneal metastasis or liver metastasis. So as a routine procedure, we mobilized the gastrocolic omentum, the duodenum was hepatic flexure, duodenum was cock-raised, and the retroperitoneal tunnel was created, and the growth was found resectable. And during all these steps, there was no adverse hemodynamic changes, so we proceeded, and we decided to proceed without going to the point of no return, that is division. So once we dissected the bile duct, the peritocoldocal nodes, the cystic duct and artery, we taped it, but we did not ligate it, and the gastroduodenal artery we ligated and divided. DJ flexure we dissected but not resected, and we found no adverse hemodynamic, so we proceeded again for division, and this showed the divided specimen. You can see the gallbladder, the bile duct, the duodenum with the head of pancreas, and the jejunum, proximal jejunum. So here the duodenum is open and you can see the periampullary growth. And this is the remnant pancreas. You can see the ductal dilatation of the pancreatic duct nicely, and behind the portal vein and the IVC. So intraoperatively there was no adverse anesthetic events. Fortunately there was no arrhythmia or hypotension, and it took around 5 to 6 hours for us to complete it. And after completion, we did a pancreaticojejunostomy, hepaticojejunostomy, gastrojejunostomy, and a feeding jejunostomy. So patient spent around 4 days in this post-operative ward, and fortunately she had some anemia. We corrected with the blood transfusion. There was no hypotension or arrhythmia, and on 10th post-op day we discharged the patient. So the post-operative HP report was a well-differentiated adenocarcinoma. So coming for the discussion, this patient we thought we'll present it because now it was almost 7 years since I operated this patient and this patient is still fine. She even came for a follow-up last week and there is no metastasis or anything. And there is the unfavorable factor she had was a dilated cardiomyopathy with a severe LV dysfunction and global hypokinesia. But she was actually referred by the cardiologist to me. And but on going for her clinical assessment and her assessing her regular day-to-day activities and her functional capacity, she was found to be thin-built, middle-aged, and an early malignancy, an active patient with no recent history of any acute cardiac events, and the surgical anatomy was favorable. It was not a small duct or not a undilated biliary duct, so that the more likely chance of a post-operative leak or anything. And intraoperatively also, we proceeded slowly and we did not have any hemodynamic changes, so we completed the procedure. So usually the rate of complications in a pancreatic resection in a patient with cardiac disease is higher than a patient without a cardiac disease, as all of us know. And the mortality is almost twice that of a non-cardiac patient. So in a tertiary care center with a high volume, with familiar with these complex operations and a full access to a good cardiac and a critical care team, these major pancreatic resections can be done in cardiac patients with an acceptable morbidity and mortality. So because of the experienced surgical staff and early recognition of any post-operative warning signs and a good critical care unit, we were able to bring this patient successfully out. And we are also happy that she has had a good post-operative outcome, and she is almost 7 years post-op. If we have not operated her, stating her cardiac condition, she would have died by this time, long time back. So, thank you.
Considering the cardiac status, it's a very bold decision you have taken. Fortunately, the patient survived.
Yeah, definitely.
Suppose, why don't you think of some local amplectomy because the dilated pancreatic duct is there? Safe procedure you have done. If amplectomy is done, I think results we have to.
Yeah, amplectomy. I even had an idea of it, but then on endoscopy and in the CT scans, it was very closer to the pancreas. And again, amplectomy, as sir knows, it always have a high rate of complication, and hence I thought we will go with the and it is not going to be if it is a Whipple's or other things for this early lesions, it may be curative, but amplectomy, again the margin positivity is going to be higher. So I thought taking this risk, it's actually the cardiac team which gave me all the support to take this patient, because this patient was on regular follow-up with one of our cardiologists, Dr. Triplus sir. So they were the one who gave me all the support to do this patient. And the anatomy was very favorable. Actually, a thin patient, there is not much of fat at all, and good, nice dilated ducts. So I just wanted to go.
The only thing is cardiac risk.
Yeah, post-operatively, if she had one arrhythmia or one hypotension, I could have not revived her.
I think, Sivaraj, it's a worth taking risk, considering the age of the patient. If you just do an amplectomy in a 27 or 30-year-old lady, because of the growing age, they are likely to get the recurrence at the earliest. So it's a calculated risk. Better to do that. And I know Sivaraj, even though he looks very pious, he's a very lion-hearted surgeon. He has been with me for a number of years, and we have done so many like this. So we'll have to take a chance, and they have taken a good chance, and the patient has lived for 7 years. It's really good. Congratulations.
Thank you, sir.
Thank you, sir. Thank you so much. I request Dr. Bhaskaran, KHM Hospital, Kilpak, to felicitate Dr. Shivraj, sir. Thank you, sir. Thank you so much, sir. Our next speaker is Dr. Kumar Gurubaran, sir. I request him to be on his stage. Yes, sir has completed his MBBS and MS at Stanley Medical College, and he is associated with our hospitals more than 2 decades. He has a fellowship in advanced laparoscopic surgery. Sir has performed 20,000 laparoscopic surgeries so far, and still counting. He has a special interest in laparoscopic hernia surgeries, and other specialization includes thyroidectomy, atherectomy, and laser and stapler hemorrhoidectomy and fistulectomy. Today, sir will be discussing on recent advances in laparoscopic hernia repair and abdominal wall reconstructions.
Good evening, esteemed audience. Thank you all for making it on a Saturday evening. Today I'm going to talk to you on hernias. So let's think why this topic, hernias, in a gastroenterology meet. I started doing laparoscopic surgery around 23 years back. And I started doing a lot of lap choles and lap appendix, and as Professor Trinakar said, the standard has been set long time back, 20 years back. What techniques we are using for lap chole and lap appendix, we are still doing the same, not much of difference. But the techniques I was doing 23 years back when I finished my post-graduation, they are not existent now in hernia. So a lot of evolution in hernias, every day, because still not reached the zenith. Still the recurrence. Still we have not conquered the recurrence. So what are the recent techniques that you're using to overcome this? A lot of exciting things have happened over the last 4 or 5 years. And that is what I want to enlighten on and share with you. So all of us know what hernia is. Hernia is an abnormal protrusion of any organ or a part of it through any of the openings in the abdomen. And composition, we have a defect, a hole which is called the defect, and the contents, and the peritoneal covering which is called the sac. So any surgeon knows that these are the 3 main components, the defect, the contents, and the sac. And what are the causes of hernia? Mostly the increased intra-abdominal pressure, and then you have the whole of the muscle weakness. So the muscle weakness may be congenital like in neonates, newborns, or an extreme of age like old age, and increased intra-abdominal pressure because of constipation or chronic cough, or increased fluid retention, pregnancies, a lot of weightlifting. So increased intra-abdominal pressures and following any trauma or any previous surgeries which weakens the muscles. And symptoms of hernia, most of the time this is one of the diagnoses where the patient himself comes up and says, "Sir, I have a hernia, I have a bulge here." And whenever I lie down, the bulge goes inside. So many times the patient themselves are able to diagnose this. And sometimes it may present in the obese patient, they may present straight away with complications like vomiting, abdominal distension. They may come at the advanced stage like strangulation. In that case, the bulge may not be very obvious. And stages, first stage is reducibility, next is irreducible, then it becomes caught or incarcerated or obstruction, and then the final gangrene. Types of hernias, it can be congenital or acquired, it can be internal herniation, it can be external herniations, but the most common nomenclature is the region where it is occurring. In the epigastric region or the inguinal region, the umbilical region, or is post a previous surgery in incisional hernias. So incisional hernias we know because of the previous incision site. Most common cause is a wound infection and inadequate rest and poor closure techniques. And there is data suggesting up to 15 to 20% of post-laparotomy people develop incisional hernias. Inguinal hernias, where we have the hernias occurring in the inguinal region. The femoral region more common in the females. The navel, the umbilical hernias, the paraumbilical, supraumbilical. And all these midline hernias in the ventral, they are all classified as ventral hernias. And then we have the hiatus hernia where the stomach slides up into the chest. And another congenital, this diaphragmatic, I'm making it fast. And diaphragmatic hernia is where there is a defect in the diaphragm. Many times it presents in the neonate, newborn period itself, and it's very severe. Sometimes asymptomatic, and only in adolescence we can find out. And Spigelian hernia is a peculiar type of hernia where it occurs in the Spigelian line. This is a lateral hernia, lumbar hernias. Many times post nephrectomy, we see most of that incisions are pseudo hernias, but in this we have a real defect there. No, treatment, all of us know the techniques for hernia, there's no medical treatment, it's going to be surgery only. The good old open techniques, and then the laparoscopy. And laparoscopy, because of the smaller incisions, the recovery period is less, and the pain is less. The advantage is more visualization, and all of us know the advantages. Now, what are the new techniques? This is what I want to talk about. The new techniques are the tap and the tip. This is the tap is the pre-peritoneal plane. Now, what we used to doing previously was the onlay mesh, where we used to close the defects and then we used to keep a mesh on the anterior aspect. Now the concept is changing. Now we are talking about posterior approaches. We are talking about posterior approaches like repairing from inside the abdomen in the pre-peritoneal plane. Now this is a good old technique which we used to talk about when around 50 years back, where we used to have the Reeve Stopa technique. We used to talk about giant processes of the abdomen where there used to be a mesh covered from epigastrium to the lower abdomen. So TAP, the pre-peritoneal, that is like what we do in laparoscopic cholecystectomy. You go inside the abdomen, open the peritoneum, go into the pre-peritoneal plane, and then we push down the hernia, and then we keep a mesh there. Now, disadvantage of this TAP technique is that because you're going to open the peritoneum and going into the abdomen, if you have a lot of adhesion, it's going to be messy, it's going to be difficult. And then it's more time consuming because you're opening the peritoneum and then again closing it. But the advantage is that we have a broader vision. You have more space. And now this is the inguinal hernia defect. I've closed with, I pulled on the pseudosac and closed it and kept a mesh and closed the peritoneum. This is a TAP technique. The next is the tip. The advantages of tip is that you don't open the peritoneum. So even if you have a lot of adhesions, you're not going to be encountering these adhesions. So less time consuming and relatively pain-free compared to TAP. And also because you don't need to see a lot of space there. You don't have to fix a mesh too much. The mesh stays there. So main advantage of TEP is that you don't have too much of pain. The recovery is faster, and especially if you're doing a bilateral hernia, the plane is an open plane. You go on one side, you can go into the opposite side easily. Disadvantages when you have some bowel pathology, bowel adherent to the peritoneum, you may miss that. You may have some bowel injury there. And the space is very less in extraperitoneal approach. Now what we are talking about recently is the E-TEP approach. E-TEP is right from the upper abdomen. TEP was what was used for the inguinal infraumbilical region. Now we're talking about E-TEP, that is extended from total extraperitoneal approach from above, even the epigastric region. Some people enter this in the subcostal, that is up in the chest, the costal margin. Now this is the TEP plane. You can see the posterior rectus sheath, the neurovascular bundle, and in this plane you can continue. If you start from the costal margin, you can go to the pubic symphysis. In around 4-5 minutes, you can just reach the suprapubic symphysis. It's a single plane. And we use a big mesh here. And this technique, we can correct divarication also. Not only the hernia, we can correct the divarication also. So that the advantage which cannot do in TAP. This is the IPOM plus. There is something like what you keep a mesh outside in the rectus sheath, we keep a mesh from inside the abdomen. And a defect, I use this when the defect is less than 4 centimeters. We close the defect, mostly for the umbilicals. We close the defect and then we keep the mesh inside. You can see this umbilical hernia. I've gone in with laparoscopy, and there's a momentum sticking there. And I've released the momentum, you can see the defect. I've closed the defect, and I placed a mesh and fixed it with tackers. And you can see the umbilicus is retracted inside after the surgery. This is yet again another case of umbilical hernia, huge umbilical hernia. A big defect there. Close the defect. And after this, place the mesh and the retracted umbilicus. Another topic, important topic and important case consideration is the complex hernias, the complicated hernias. What are you talking about? Complex hernia. How do we manage this? Now, complex hernias are where the anatomy is completely distorted. We do not know which is the rectus sheath, which is the peritoneum, which is the rectus, or which is the lateral muscles. And so closure of these abdomen defects is not easy. So this is an entity what you call as loss of domain, where you have the complete pandemonium there. We don't know what is the anatomy there. So the exact definition, when you have the extra-abdominal hernial contents of more than 30% of the intra-abdominal contents, you can call this as a complex hernia or a loss of domain. Now, what are the new techniques that we are using apart from the previous older ones? We can have component supination, Botox, posterior peritoneum, pneumoperitoneum, and fasciotens. This is a new device. So what is the problem with the complex hernias or loss of domain? Because you want to close the sheath, you want to close the defect, but you don't have sheath to close the defect. If you have it under too much of tension, it's going to cut through, you're going to recur. So how do you manage that? And that is what these new techniques are about. All of us have heard about Botox. A lot of us have seen Botox being used by a lot of actresses. They say we put Botox in the face, like that. So it's a neurotoxin which causes flaccid paralysis. So what we are doing is we're injecting this into the muscles, the lateral muscles. So as you know, we have 3 lateral muscles, the external, internal, and the transversus, and the midline, the rectus. So we're injecting this Botox into the lateral muscles up to at least a month prior to surgery. And this causes flaccid paralysis and over a period of time, lengthening of the muscles. So what happens is you have lengthening of the muscles, so the defect closure is easier. This is done up to 3 to 4 weeks, up to a month before the surgery. Other technique is the good old positive pneumoperitoneum. When I was studying in Stanley Medical College, we used to talk about this, but it was not an easy thing to create pneumoperitoneum because laparoscopy also was not there at that time. So now the techniques are coming back. So now what we are doing is that again to stretch the abdomen to get more length of the fascia to close. So positive pressure, we recently we did 2 patients where I have introduced pigtail catheter under ultrasound guidance into the ultrasound, so by the sonologist in the peritoneum, and I kept inflating the abdomen till a point of time when patient started having some discomfort in breathing. And the volume is depending upon each and every patient. And I found that most of the pneumoperitoneum was going into the abdomen, the hernial sac rather than the peritoneal cavity. But then I continued with that for 10 days and then I took up. So this leads to strengthening of the elongation of the muscles. And not only that, it releases some adhesions intra-abdominally and also gives the respiratory reserve boost for the patient. Now this is the latest device which is been excitedly talked about in such cases where you have this fasciotens. So most of us are using this technique of pre-peritoneal closure. So we have a mesh, the pre-peritoneal plane, and stretching of the fascia. There is a vertical rod there, and this is done intraoperatively. Vertical rod there, we take sutures on the fascia hang up the fascia like for half an hour to 45 minutes. And then we have the lengthening of the fascia. We're able to close the abdomen. This is not been, I think each and every case, 1.5 lakhs is what they are charging right now. So not very widely practiced, but for such cases, it's worth it. And abdominal wall reconstruction, no more hernias looked at as a local defect. It is called abdominal wall failure. Why is recurrence coming again and again? Because it is not only the hernial defect which is the problem. We are talking about abdominal or the systemic failure. So now we are trending to address the hernia as a abdominal wall failure and trying to treat the whole failure as such. So we're not confined to the hernia as such. This is a retromuscular strain. What are the various things in this abdominal wall reconstruction is, we have the anterior separation, component separations, posterior separations, and then the transverse abdominal release. These are various surgical techniques. You'll not like to go into this. And of course, robotic is come under a big way in certain centers. But more so like stepping stone, they want to train in something before they're going for, they learn robotic. It's more like learn with robotic, hernia. Now, the other entity that is we are talking about is the divarication. Many times this is missed, especially post-pregnancy. Patient comes with an umbilical hernia. All of us jump into the surgery and say we'll do the umbilical hernia. Invariably, they come with a recurrence because most of these, especially the females, they have divarication. That is, the gap between the muscles more than 2.5 centimeters. And if you don't address this, it's going to come up with a recurrence. So this technique for laparoscopic correction of this divarications called SCOLA, subcutaneous laparoscopic surgery. You see, we make a subcutaneous plane with laparoscopy, we introduce pneumoperitoneum, and we define the rectus. And the rectus is approximated, rectal muscle approximated, and then the onlay mesh is placed. So this is, the ports come just in the suprapubic region. It's almost like scarless. What happens if you have a pendulous abdomen as well? If we have a hanging apron and with a divarication, obviously divarication character is not going to help in such patients. So you have to go for a abdominoplasty, where you read the ripectomy, where you excise the hanging apron as well. This is one of my patients post-pregnancy, 2 years, completely distorted abdomen. And I did abdominoplasty to reconstruct the umbilicus. She's doing fine now. Another entity, the most important thing, why this topic, why so many techniques are coming up, recurrent hernia. So, the recurrent hernias are what actually is driving us for all these techniques, prevent recurrence. And if you ask me whether we have reached the perfect techniques, still no, we're still trying. Main cause is proper evaluation of the patient. What are the precipitating cause for a recurrence? What are the patient characteristics and the proper technique? Because I know laparoscopy should not be like I should do only TEC or ATEP, or I know only open, I should be doing only open. The proper patient selection and post-operative follow-up is what most important to prevent recurrence. Thank you for the patient hearing.
Thank you, sir. Thank you so much, sir. Sir, any comments? Thank you, sir. I request Dr. S.R.A. Rao, sir. To felicitate Dr. Kumara Gurman, sir. Thank you, sir. Thank you so much. I request Dr. Elankomaran, sir, to be on stage. He is internationally renowned hepatobiliary surgeon for adult and pediatric liver transplantation specialist with an experience of spanning over 17 years. He has successfully performed more than 5,000 complicated liver, biliary and pancreatic surgeries and over 1,500 liver transplantation with 95% of success rate.
Thank you.
Sir.
I think it's the same like this time. So let's start off with the presentation.
Yes, sir.
So, respected chairpersons, my teacher, Professor M. Subramaniam sir, Dr. Sivarajan, distinguished colleagues, and my dear friends, it has been a pride and privilege to be a part of this CME because we all know BIG, or the Billroth Institute of Gastroenterology, has been the torchbearer department for the Billroth hospitals. They are well known for their advanced gastroenterological care. I'm sure all other services are now in the world class, but the department that is something very close to their heart is always gastroenterology, established by the founder himself. So I thank the leadership of Billroth, Medical Superintendent Dr. Shanmugh Priya, Dr. Chakravarti, for giving me an opportunity to be with all of you here today. So, liver transplantation is not about transplanting livers, it is about transforming lives. With every transplant, we really feel that the life of the person gets transformed, and not just the patient himself, but the entire family. So, this is one of my favorite quotes from Professor Thomas Starzl, rightly called the father of liver transplantation. What was conceivable yesterday and barely achievable today often becomes routine tomorrow, which is very true about liver transplantation, because the advances that have happened technologically, immunosuppression-wise, and the patient care monitoring, everything has brought liver transplantation to a state where it can be done successfully in almost 95% of patients in established centers. And we have been very happy that we were able to establish a very successful department at Billroth Hospital. And so I'm also very happy to be a part of the team which made the dream of Dr. Vijay, the founder of Billroth Hospitals, to bring liver transplantation, which is to make complicated surgeries affordable and accessible to all sections of society. And in his footsteps, the managing director, Dr. Rajesh, also have been very kind and gracious to establish a fully equipped liver transplant department at Billroth Hospitals. It was inaugurated in September 2021, and we have successfully done multiple surgeries now. So the team, it is not me alone. The liver transplant team includes Billroth Institute of Gastroenterology, the gastroenterologist led by Professor Mohammad Ali and the entire team, and Liver Disease and Transplantation Institute, which would include the surgeons, anesthetist, intensivist, and the hepatologist. The liver failure unit and the intensive care also play a major role in the pre-operative and post-operative care of these patients. Dedicated operating theaters, fully equipped imaging, laboratory and blood bank services, which are very essential, and experienced multidisciplinary experts. And finally, not to forget the dedicated support staff, which are nursing, the coordinators, managers, physiotherapists, and dietitian. So all of them work together to make liver transplantation successful. So I thank Rachanya, our manager, for sharing these pictures with me. These are the pictures of one of our patients who came, a very typical picture of a chronic liver disease patient who comes to us, completely sarcopenic, distended belly with a lot of ascites, jaundiced, discolored skin. And he was one of the fortunate patients who underwent a successful liver transplantation. As you can see, it is also a visually very gratifying operation where a completely damaged liver is replaced with a beautiful looking functioning liver, and the outcome is this, where exactly 2 weeks after a successful liver transplantation, a completely bedridden patient was able to resume his normal activities and become completely independent. And not just in adults, these are some of the children that were referred to us in end-stage liver disease, and after transplant you can see that they are all growing up happily to become normal children and hopefully add value in the society. So I would like to start off by quoting a few successful transplant surgeries. This patient was diagnosed with cirrhosis and liver failure. This was at the first peak of pandemic, so he could not come for a personal visit. We contacted him online. So as doctors, we always try to help our patients, innovate methods. So this was the first time we did not see the patient. We did a virtual consultation and reviewed all his reports, discussed with all the caretakers in his hometown, and then finally we were able to list him for a disease donor transplant. He was not able to come for a checkup because of the continuous lockdowns. He traveled on an emergency when the liver was allocated, and he underwent successful liver transplantation, and the post-operative care was excellent and he recovered well. And so this is the patient exactly 10 days after surgery, and not just him. Like I said, it is a new life, normal life for the entire family. And this child, 2-year-old, had developed fever with jaundice for a week. Even after extensive evaluation, no specific etiology could be identified, but the child started slipping into rapid liver failure and unconsciousness. His bilirubin has increased up to 45 and INR of 3.5. An acute liver failure was diagnosed and the family was counseled. His father was found to be fit for liver donation, and after all the evaluation was done, they underwent a successful living donor liver transplantation. The donor was discharged on day 5 and the child was discharged on day 8. And this picture shows the preoperative and postoperative picture of the child, and you can see that there is no difference, and this is what transplant is all about, giving back normal life to every patient like we do. And this elderly woman, 69 years, was diagnosed with a cirrhotic liver, and she started developing recurrent encephalopathy, multiple hospital admissions, and even at 69 years, the desire for her to lead a normal life for the rest of the time was very high. So we evaluated her, listed her for deceased donor transplant. She waited almost 8 months and finally got an organ allocated, and she underwent a successful transplantation, as you can see. And in her case, we used a recent advance, which is advanced organ preservation using machine perfusion. I will explain in detail later. So in this patient, in spite of a higher fat content in the donor organ, almost 30 to 40%, we were able to do machine perfusion, and then she underwent an uneventful surgery and discharged on day 7. So, as we all know, transplantation is not just a successful treatment for liver failure, it is also a successful treatment for liver tumors. This young lady, 25 years, was evaluated for pain and weight loss, and unfortunately diagnosed with multiple nodules, a rare tumor called hepatic epithelioid hemangioendothelioma, which could not be resected. It was bilobar, large nodules, and hence was advised transplant. Her uncle was fit for donation. She underwent an uneventful living donor liver transplantation and is now recovered well and leading a normal life. So not just this tumor, hepatocellular carcinoma, selected patients with colorectal metastasis and neuroendocrine liver tumors may also be suitable candidates for liver transplantation at present. And conventional contraindications like portal vein thrombosis, which were considered as contraindications for liver transplant, and or they had to undergo a multivisceral transplant, because without a portal venous flow, the liver graft cannot survive in human body, and hence they were considered contraindication or a multivisceral, which is a much complex operation. But with more experience and surgical technique, we were able to perform transplant for this patient, in whom you can see that the portal vein is completely blocked by a thrombus. There is no portal vein, and we were able to remove the entire thrombus in one mass. And this is the diseased liver, and this is a video showing the re-establishment of portal flow. It's not working, but then immediately after reperfusion, you can see that the liver has started functioning, the bile is secreting, and the liver looks healthy and pink. So this is the patient recovered well after surgery. And coming on to the next major advancement in surgical technique, which is minimally invasive surgery in hepatobiliary, especially hepatectomy and donor liver surgeries. This patient, 78-year-old male, was detected to have a large tumor in the liver, almost 8 into 7 centimeters. It was a non-cirrhotic liver, viral markers were negative, and no evidence of distal spread. So you can see that the CT scan is showing a large tumor in the left lobe. So he was evaluated, and at this point he had an option of going for an open surgery or a minimal invasive surgery. In the other hospital that I work, we fortunately have a robot, and he wanted to go for the robotic surgery. And it is pretty much the same as the open technique, where the inflow control is taken, the parenchyma is transected, the hepatic veins are divided, and finally hemostasis is secured. It's a short video of the surgery being done by the Da Vinci surgical robot. You see that the hepatic arteries are dissected, they are clipped and divided, which is the inflow. you can see that the dexterity of the robotic instruments, it has an endo wrist, and hence they are much more capable of controlled dissection and division rather than the robotic surgery, which is very essential for hepatobiliary surgery. And next, the portal vein is dissected and it is ligated. Suturing is very comfortable with a robot. And this is one of the other important advantages of a robot. This is a firefly technique where you inject ICG and turn on the firefly mode. You can see that after we have ligated the right hepatic artery and right portal vein, left hepatic artery and left portal vein, the greenish color was only on the side of perfusion, the right side. So we can mark the transection line using this firefly technique accurately. And this is a method to retract the liver along the transection line. And we are using a robotic CUSA and other robotic instruments for retraction and division of the liver. And the transection now, these days, is pretty much completely bloodless, thanks to our anesthetists who do a great deal in maintaining their hemodynamic stability and at the same time avoid blood loss, maintain the coagulation parameters for the surgeons to have a bloodless field. And you can see that major hepatic veins that are crisscrossing the parenchyma of the liver, they are identified and then divided. The accuracy of robotic surgery is because of the magnification, which is almost 10 times, 10x magnification that is available with the robot. And these look like a big veins, but in actually they are not more than 4 to 5 millimeter size veins. And you can see that the veins can be ligated, clipped using multiple devices. And finally, the hepatic vein is stapled using a endostapler. And the specimen is actually retrieved through a fan and steel incision. So this was the final specimen, which showed moderately differentiated hepatocellular carcinoma. The margin was free of tumor and no vascular perineural invasion. The advantage of robotic surgery is this: the patient was mobilized on day 1 and got discharged on day 2, which is a huge functional benefit for the patient. And every time we had to do this open incision for a liver surgery, and you see a scar in the postoperative period like this, we always had the motivation to go minimal invasive, and finally we are happy that we are able to offer minimal invasive to all our patients. And this is the scar after robotic surgery, where you can see that there are 5 small holes, 8 millimeter size, and this is a fan and steel incision. This is actually a muscle splitting incision compared to the muscle cutting incision of this, so it doesn't interfere with the breathing in the immediate postoperative period, doesn't give an unsightly scar. So apart from cosmetic benefit, it has a huge benefit in the functional recovery of these patients. And definitely in also donor surgeries, where can also be done by robotic technique. This young child, 2-year-old, was diagnosed with the extrahepatic biliary atresia and having a cirrhotic liver. His father was found to be a suitable liver donor, and the left lateral lobe was planned for donation. And this is the conventional ports of the Da Vinci, where you put 5 ports. This is the assistant port for the laparoscopic CUSA, suction and staples. Otherwise, the 4 arms of the robot are inserted in these ports. And finally, this graft can be retrieved through the fan and steel incision. This is again a short video of the robotic donor surgery. And the difference in donor surgery is that you cannot divide the hepatic artery and vein. Inflow cannot be divided before the parenchymal transection is completed, because it's going to take many hours before you can actually retrieve the graft. The inflow can be divided only just before the graft can be taken. So more precise dissection is required. The maintaining of hemodynamic stability in these donors is also a big challenge, and the anesthetists are able to do it very well these days. And the dissection starts off with mobilization of the liver, and the portal dissection, which is a very important part. You can see that starts with the gallbladder being mobilized and the cystic duct divided, gallbladder removed, and then the hepatic artery and dissection starts off. So, yes, so these the dissection of the hepatic hilum. The artery is identified, dissected, a long length of the artery is dissected, and then the dissection of the portal vein is also done. It is slinged using vascular loops, but not divided like in hepatectomies. And this is also an important maneuver. Taking a Huang's loop is what we call it, passing a Foley's catheter across the portal structures. It is loosely left, and if there is a bleeding, you can actually tighten the sling to achieve good hemostasis. And the transection line is marked using a temporary occlusion with bulldog clamps, and then the transection is started using a laparoscopic CUSA equipment. The robotic CUSA is still not yet available. It is being devised. Maybe in a few years it may be available now. Till that time, the RoboLap approach, where there is another experienced surgeon at the bedside doing the laparoscopic CUSA, is a very, very safe and useful technique. And as you can see that the parenchymal transection again goes on in a very bloodless manner, very controlled dissection, identifying all the important structures. Here you can see that the bile duct is being divided, and finally, after the entire transection is completed and the portal structures are taken, the portal vein, artery, the hepatic vein is also divided using a endostapler, and the graft can be retrieved using the phalansteal incision. Yes. So this is the child while discharged. The donor, his father, is completely recovered, and that is a huge advantage. So coming to other recent advances in liver transplant, like I said, machine perfusion of liver. Normally, the technique of preservation of any retrieved organ is called static cold storage. Once the donor is perfused with an organ perfusion solution, the organs are retrieved and put in a box of ice with organ preservation solution. But this has a limitation where the preservation time, especially for liver, is not more than 8 to 10 hours. But when you can place the livers in machine perfusion like this, you can extend the preservation time beyond 10 hours. Even 4 to 5 days have been studied abroad, and also in marginal organs with higher fat content, organs who are not been, donors have not been maintained very well. These organs, if they can be perfused using the machine, the quality of the organ becomes much better. This machine is called normothermic perfusion machine. The liver is kept in this box. Blood at normal temperature is perfused into the liver, and the effluent blood can actually be checked for lactates, it can be checked for bilirubin, it can be checked for other metabolic parameters to assess the function of the liver, and only if you are convinced that the liver is functional, you can proceed with the recipient surgery. So this machine was briefly available in India, the normothermic perfusion machine. It is a very expensive machine and not available anymore, and our experience is one of the largest with machine perfusion using this machine, which is called hypothermic oxygenated perfusion, where a special perfusion fluid which is oxygenated is perfused in this bowl of ice using this machine. This also has successfully, in all the 6 patients that we have used, extended the preservation time, improved the graft quality to such an extent that the ICU stay of these patients was much shorter. The laboratory peak levels of enzymes, bilirubin, everything was much lower than what we would have expected in these patients. So, conventionally, blood group compatibility is very essential for liver transplantation, but that barrier has been overcome already. In selected patients in whom the antibody titers are not very high, you can select these patients even if they are the recommended titer levels are 1 in 16, but even if it is 1 in 512 or 1 in 1024, you can actually subject these patients to multiple sessions of plasmapheresis, give them immunosuppressants so that their antibodies against the blood group antigen titers are reduced, and then finally you can transplant in these patients without increased episodes of rejection, and main other complication is the non-anastomotic biliary stricture. The long-term outcome in these patients who undergo successfully ABO incompatible transplant is equal to compatible transplants, and the protocol is to have plasmapheresis if it is required, and give them rituximab, which is an anti-CD20 monoclonal antibody 3 weeks earlier to surgery. It is very interesting to note that A2 subgroup donor can donate to O group recipient. Normally we would consider an A group donation to O group recipient is an incompatible match, but the A2 subgroup does not have enough antibodies in the recipient, and hence if there is an A2 donor, he can donate to the O recipient without any incompatibility or higher risk. And the outcomes, like I said, has been proven in multiple trials that it is equal. So these are some of the protocols where you give rituximab 3 weeks before, start them on multiple sessions of plasmapheresis, start immunosuppression before, and end up with a successful surgery. And the last innovation that I would like to enumerate is about APOLT, which is auxiliary partial orthotopic liver transplant. Normally in a liver transplant surgery, the entire recipient liver is actually removed. But then in APOLT transplant, you leave behind a portion of the native liver and transplant only a small portion of the graft. Why do you do this? We will come to know, but as you can see that the native liver is only useful only in selected patients. In patients with acute liver failure or patients with metabolic liver diseases, only these patients are suitable for APOLT transplant. And immediately after transplant, you can see that the native liver, this is a HIDA scan showing differential function. The native liver is contributing to less than 10% of the liver function, 90% or more is by the graft. 3 months later, we all know that these grafts can regenerate, especially in acute liver failure. Immediately the function is very less, but the risk reduces when the liver can actually regenerate. So just because you have left behind a portion, significant portion of the liver, it has regenerated. At 3 months, it is contributing to almost 43% of liver function, and the graft only 57%. At this point, if you can actually stop immunosuppression, the graft undergoes atrophy and the native liver takes over the normal function, and essentially this patient is no more a patient. He starts living with his native liver, and transplantation has only become a bridge to recovery. So many more innovations are coming up which will make liver transplantation definitely much safer and much more available to all our patients now. So definitely liver transplantation is a safe and successful treatment. An early referral is key to the successful outcome, and with the wealth of experience, especially in countries like India, Korea and Japan, living donation is definitely a foolproof surgery. And finally, modern techniques are overcoming the traditional barriers for liver transplantation, and never more than now is the need for organ donation, which has to bridge the big demand for organ shortage. So in patients who cannot afford, definitely there are several ways of doing liver transplant for all these patients. Billroth is a hospital which definitely helps a lot of needy patients. We have had in our own experience. The Chief Minister's scheme provides transplant at no cost for these patients. Whoever gets an approval can get transplant at no cost. And the non-governmental organizations like Milap, Ketto and Impact Guru can do crowdfunding and help these patients. Once again, I thank Dr. Rajesh and the entire leadership of Billroth, the senior members, and all the distinguished guests here today for listening to me patiently. Thank you.
Thank you, sir. Thank you so much. Sir, any questions? I request Dr. A.P. Arnachalam, sir, to felicitate Dr. Ilankumaran, sir. Thank you, sir. Thank you all. I request Dr. A. Chakravarti, HOD, CCU and Emergency Billroth Hospitals to deliver a speech.
Good evening, one and all. Thanks for coming and to make this event so grand success. congratulates Department of Gastroenterology, Medical and Surgical, or Billroth Institute of Gastroenterology for making this program so successful. I'll congratulating all the faculty for this active participation and good lectures in this evening. And as a clinician from Billroth hospitals, we are coming up with more and more cutting edge technologies in the field of cardiology, in the field of solid organ transplants, and we are in our 24/7 imagiology, our emergency and critical care services, round the clock dedicated faculty is always ready to take care of patients. And we are newly launching our Billroth Diabetic Foot Clinics BDFC is the next program we are inaugurating, and we'll come up with the taking care of in the field of diabetic foot clinics. Without the support of the referral doctors and the faculty, definitely this is not possible. So always the mantra of Billroth believes in affordable cost, good quality service to the patients. That is the vision of our founder, and it has been carrying away by our founder under the leadership of Dr. Rajesh Jagannathan. We definitely do more and more wonders in the field of clinical services to the patients. And we are not only in the treatment part and clinical services, in the part of academics also we are running various programs. In future also we have every month newsletter will come from the organization, and every month we are going to conduct CMEs in various departments. We expect the same kind of support from all of you to make this way forward. Thank you all. Thank you once again.
Thank you, sir. Thank you so much. I request Dr. Valli Shanmugapriya, Medical Superintendent of Billroth Hospitals, to deliver the speech.
A very good evening. I stand before you all today with immense gratitude as we conclude this CME. Such a lovely gathering on a Saturday evening. Thank you so much. I really thank each and every one of you present here on behalf of Billroth Hospitals. Thank you. Special thanks to Dr. Subramaniam sir for being the chairperson for this wonderful session. Thank you so much, sir, for your guidance always. And our dear CR sir, thank you so much for your kind presence here too. Thanks to our respected MD sir for continuous support and encouragement in making the CME happen. I would like to express sincere appreciation to our distinguished speakers for their outstanding presentation and discussion. Your expertise has enriched our knowledge and provided invaluable insights that will undoubtedly enhance the quality of healthcare we provide. I thank our hospital consultants and consultants from various hospitals who have joined us and made the event more special. Our Billroth family would be happy to work together with all of you with continued medical services. A special thanks to CFO, Mrs. Satya Madam, CAO, Mr. Vasant Jesli, CBO, Mrs. Bharati, for their immense support in executing the CME. Special thanks to Dr. Chakravarti sir, who is one of the strongest pillars of the hospital. Thanks to Dr. Vishneshwar for helping us in all aspects in executing the CME program. Thanks to our entire marketing team for your fantastic coordination and excellent support. Without you people, this would not be possible. Thanks to our branding team, Mr. Valarasu, SEO Mr. Lokesh, Ms. Pooja for helping us in all aspects in promoting the event. Thanks to HR team for their unwavering support. I extend my heartfelt thanks to all who have contributed to the CME program. Thank you all once again, and let's look forward to more enriching opportunities in the future. Request you all to join for the dinner served right now. And we will have a night collaboration with all of you in further CME programs too. Thank you so much, each one and every of you. Thank you.